And it's not an easy decision about what to do next when immunotherapy fails. I had a patient that had some apparent pseudoprogression, but then that was followed by a significant decrease in the size of their lesion. And then as we thought things might be heading towards complete response, on one side of the original target lesion area, there was a new tumor growing, and it was found to be squamous cell. And that tumor, for unknown reasons, wasn't seeming to respond. But the fact that the patient had a much smaller tumor than when he first saw me and when treatment was first initiated meant that we could go back to the head and neck surgeons, and then they had a tumor that was much more resectable with a higher confidence obtaining clear margins. In terms of patients who progress with limited options, there's not a lot right now. The question is, for the future, could combination therapy, an anti-PD-1 plus something else, actually be effective in cases where an anti-PD-1 alone may not be? That's an area of investigation, potential investigation. So if we think about returning patients to old therapy, which would be systemic therapy of the chemotherapy or EGFR targeted agent category, you have to think about the lower tolerability, the higher rate of adverse events, whether the patient can stay on that therapy, and the lower response rate typically found in those therapies compared to immunotherapy. So the prognosis of people that have a complete response on immunotherapy such as anti-PD-1, cemiplimab, others, is good. But the data is limited. We have case reports where people have had durable responses. We have the initial data from the phase 2 trial. We don't have years and years of follow-up at this point in terms of any sizable population. So that remains to be seen what the true prognosis is. I'm very encouraged by the results that I've seen so far, and that I have multiple patients that have had complete response, of which many are off therapy now, and they still have no evidence of any disease. So that's very encouraging. That's not definitive. And until we have longer interval follow-up data from these trials, it's hard to say with certainty. Well, the recommended follow-up after treatment concludes is basically standard of care for surveillance if the patient has had a complete response. If they haven't had a complete response, it would be standard of care follow-up to check on the status of their tumor. So I'm thinking in terms of once a month for some period of time, and then reducing the frequency down to every 2 to 3 months. And if the patient has a complete response and they're a couple of years out, we can spread to 4 to 6 months. So that's the kind of interval that I think of in terms of follow-up. And of course, it depends on how complete the response and how far out they've been.